privilege to present our team's work from over the last 15 years. So Dr. Kelly West is known as the father of diabetes epidemiology, and I've spent a little bit of time reading about his work. He was working in Native American populations as well as in the WHO multinational study. And I came upon this quote, and I think it's very poignant. It says, "The major variation in arterial disease prevalence between national groups could be accounted for only in part by the risk factors studied. Other factors, genetic or more likely environmental, are likely to contribute to arterial disease susceptibility, and if definable, may be potentially preventable." So that's prescient, and that's exactly what we've been trying to do with our study of South Asians. Before I present any of our research findings, I wanted to just take a moment to acknowledge my main mentor, and that's Dr. Elizabeth Barrett Connor. For those of you who may not have had a chance to meet her or know her, she too was a pioneer of diabetes epidemiology, and she was awarded the Kelly West Award in 1987. And it is so poignant and humbling for me to receive this award in San Diego, because this is Elizabeth's town. And this is where we used to meet and talk about the need to study South Asians and why is there so much diabetes and heart disease in South Asians, and what can we do to change that? And how do you convey the public health significance of this work to reviewers who are not aware? So I know Elizabeth is here with me today. So in my research fellowship, I started to look at the South Asian data from around the world, and what I found was everywhere South Asians have migrated to, there seems to be a higher risk of diabetes and heart disease in cross-sectional studies. And this is true for the United Kingdom, this is true for Singapore, South Africa, Canada, and some small studies in the United States. But the question is why? And there were no longitudinal studies of South Asians. So that was the genesis of this idea, to have a longitudinal cohort of South Asians in the United States to really answer some of the why questions. Great idea, right? Yeah, it took 5 tries to get my first grant, a K-23, to actually get preliminary data in this population to be able to show that there is some uniqueness of this phenotype, the South Asian phenotype, compared to other US race and ethnic groups. And it's not only that South Asians account for almost a quarter of the world's population, that's why this is important to study, it's because when you study populations that are high risk for disease, you may uncover novel pathophysiology or novel approaches and methods to prevention and treatment of disorders. So that was really the genesis of the Masala study. So what do we know about South Asians in the United States? Well, Asian Americans are aggregated together as one race category in the United States, but they actually represent people with origins from 23 countries. And we know that Asian Americans have had the most growth in terms of the census data. Asian Americans now account for 7% of the US population, and as of last year, Asian Indians are the largest Asian subgroup in the United States, representing more than 4.5 million people. So the National Health and Nutrition Examination Survey started to oversample Asian Americans in 2011. And in this project, we worked with CDC colleagues to look at the NHANES data, pooling together 3 waves of data. And these are the 4 main race and ethnic subgroups in NHANES. And you can see there's big differences in diabetes prevalence. Non-Hispanic whites have the lowest prevalence at 12%, and Hispanic Americans had the highest prevalence of 22%. So working with CDC colleagues, we were able to further disaggregate the Asian data into 3 geographic clusters. And that was East Asians, representing Chinese, Japanese, and Korean individuals, South Asians, Indian, Pakistani, and Bangladeshi individuals, and Southeast Asians, Filipino, Vietnamese, and Indonesian. And what you can see here is that there's as much heterogeneity in the prevalence of diabetes among these 3 geographically clustered Asian groups as there is among all of these other US race ethnic groups, and it gets lost when you aggregate all Asians together. And South Asians did have the highest prevalence of diabetes. And so that is really one of the main goals that we've been trying to study, is the why, and by doing a longitudinal cohort. So MASALA stands for the Mediators of Atherosclerosis in South Asians Living in America. And we enrolled people who were of South Asian background. The age range was 40 to 84 years, and they had to have no cardiovascular disease to be eligible to join the study. And we used community-based sampling methods. There were 2 clinical sites originally for MASALA, and that was at UCSF, where I am, and Northwestern University. And this is the only longitudinal cohort of US South Asians. And we purposefully created MASALA to be parallel in methods and measures to the ongoing multi-ethnic study of atherosclerosis. And this is a very large NHLBI-funded cohort that includes white Americans, Black, Hispanic, and Chinese Americans. And this was an important thing to do, and I'll give Elizabeth credit. This was her idea, is like we couldn't make the case for funding a South Asian-only cohort in the US after 4 or 5 tries, and actually having a comparison group with an ongoing contemporary cohort that included many other groups was the key factor that I think actually made MASALA fundable. And so I'm going to be using this color scheme for any of the slides that I show that compare MASALA to the 4 groups in MESA. So here's what we've accomplished in MASALA, and I want to shout out to my friend and long-term colleague, Dr. Nami Kandula, who's been a partner with me for MASALA since the very beginning. So we completed our exam 1 for the cohort in 2013, enrolling 906 participants. And exam 2 was completed in 2018. We were able to add another 258 participants at that time. And currently we're in the middle of exam 3, bringing people back to study heart function. And we were given a new grant to expand our cohort, and we call that Wave B. We're enrolling 1,150 new participants, primarily Bangladeshi and Pakistani in origin, to be able to compare the 3 largest South Asian subgroups. So currently the cohort size is 1,164, and that's the data I'll be sharing with you for the rest of this talk. But by next year, our projected cohort size, once we complete Wave B, is 2,300. So who are the participants in MASALA? Well, 98% are immigrants to the United States. And again, remember, the age range was 40 to 84, so this is consistent with US Census data. In that age group, most South Asians in the United States are immigrants. 83% were born in India, 6% in Pakistan, and 1 to 2% in the other South Asian countries. And this is, part of the reasoning for why we need more data, including Pakistani and Bangladeshis, because we don't have enough representation in MASALA right now. We just completed whole genome sequencing of our cohort, and I wanted to show you some of the genetic ancestry that we've looked at. And indeed, everybody in the cohort is South Asian by genetic background. There's 3 population substructure groups as expected, and you can see that in orange is the ancestral North Indians, in red is the ancestral South Indians, and that cluster to the right is the Indus Valley Civilization steppe populations. So who are the people in MASALA? About half men, half women, and about half come from Chicago and half from the SF Bay Area. The mean age was 57, and they've lived in the United States about half their life, so about 28 years spent in the United States, a nice normal shape distribution. And this is a very highly educated and high income group, with 86% having a bachelor's degree or higher. And this is also consistent with US Census data, because the only people who were allowed to immigrate to the United States as of 1965 Immigration Act were people who were coming here for higher education or people who had professional degrees. So this is consistent, again, with census data with the high education group. And that's something for you to keep in mind in terms of, do our results generalize to other South Asian populations who immigrated later? Do they generalize generalized to other South Asians across the diaspora, because this is a very different demographic of South Asians in the United States. So now that I've introduced you to the methods and the demographic characteristics of our study population, I'm going to spend the rest of the time talking about two big things that we've learned, just summarizing the highlights of our results. First on diabetes epidemiology and pathophysiology, and the next on the multi-level modifiable risk factors. So starting with diabetes epidemiology, we found that the prevalence of diabetes in Masala participants was 26%. And this is based on fasting glucose, 2-hour glucose tolerance test, and if someone was taking a diabetes medication. And you can see there's a gender difference, with men having higher prevalence at 30% versus 21% in women, and about a third have prediabetes. Now, how does this compare to the 4 groups in the multi-ethnic study of atherosclerosis? So Dr. Elena Flowers did this analysis, and South Asians are in orange here. And you'll see that the prevalence somehow shrank from 26 to 21, and that's because MESA did not do oral glucose tolerance tests. So in our comparison with MESA, we just use fasting glucose criteria and diabetes medication use. So without any adjustment, just the crude prevalence of diabetes was much higher in the South Asians compared to all 4 groups in MESA. And then with serial adjustment for socioeconomic factors, behavioral factors, metabolic factors, body composition, this difference got only further exaggerated, with South Asians having 27% prevalence of type 2 diabetes, almost 4 times as much compared to the whites, and almost twice as much compared to the Chinese, the Black, and Hispanic Americans in MESA. Why? And so we looked at data among those without diabetes in Masala to try to understand why, and we used surrogate measures of insulin resistance and beta cell function. And on the left, I'm showing you HOMA insulin resistant levels, and in orange are South Asians, and the other 4 groups in MESA are shown in different black lines. You can see the insulin resistance measures are much higher for South Asians, at least till about age 65. And HOMA beta was very interesting because across the entire age spectrum, there's lower pancreatic beta cell function in those without diabetes. And that is something that there has not been enough emphasis or research on in South Asian populations. We also looked at these measures of HOMA insulin resistance and HOMA beta for across the usual surrogate markers of adiposity, BMI, and waist. So the top 2 graphs show you body mass index going from 20 to 50. And again, the South Asians have higher levels of insulin resistance, and then they flatten out after 30 because there's very few people actually with the BMI that high in the South Asians. And for waist circumference, you can see that the South Asians have higher HOMA insulin resistance level across the entire waist spectrum. And again, for HOMA beta, across the BMI spectrum, HOMA beta was much lower in South Asians and also across most of the waist spectrum. So again, saying that there's beta cell dysfunction happening here, that seems to be relevant even at very low BMI, and same with insulin resistance. So what can we learn from those with diabetes? And this paper was led by Dr. Michael Banks, and he looked at the people with diabetes in both MESA and Masala, and he looked at all 5 groups, and I wanted to see what different types of diabetes there was, the different subtypes. And he also was able to look at the subtypes and how they correlated to future development of diabetes complications like chronic kidney disease, as well as progression of atherosclerosis using coronary artery calcium as a surrogate measure. And what he found were there were 5 distinct subtypes of type 2 diabetes. The most common one was the older age at onset, shown in blue. The second cluster was a severe hyperglycemia one, and that was one with high levels of hemoglobin A1C and low beta cell function and very modest BMI, not high BMI. And the third cluster was a severe obesity cluster, which was, again, high BMI and high insulin resistance. The fourth was insulin use, so people who had basically exhausted their pancreas and had to be on insulin. And the fifth cluster was younger age at onset, very, very low in prevalence. And what this graph shows you is the distribution of those 5 distinct subtypes for each of the 5 different race and ethnic groups. And I draw your attention to the South Asians in the very far right bar. And what you'll see here is the most common subtype is the orange one, which is severe hyperglycemia. So that's the one with the low pancreatic beta cell function and the high hemoglobin A1C levels. And the next most common is the older age, and then insulin resistance. So again, coming back to that idea is like we have been focusing so much in the literature on insulin resistance being the driver of diabetes in South Asians, but we're seeing a pancreatic beta cell dysfunction as being more common. And I want to make the distinction between the Chinese Americans and Mesa with the South Asians and Masala. And so you can see that in the Chinese population, 67% had the older age of diabetes subtype, and only 22% had the severe hyperglycemia subtype. So when you aggregate Asian Americans together, you are losing this nuance, and you are treating everybody in the same way when there's clearly big differences among all of these 5 groups. So what do these subtypes mean in terms of long-term outcomes, and why does subtype matter? So I'm showing you that the South Asian bar again over here to reorient you. And again, that severe hyperglycemia subtype was most common. And what Dr. Banks found in this paper was that that group had the highest incidence of developing coronary atherosclerosis, so CAC. And so that is important because, again, all of the world's literature in cross-sectional studies has shown that there is higher diabetes and higher heart disease. And this may be one of the reasons that there is so much heart disease, is there is this propensity to having this severe hyperglycemia subtype. And maybe patients who see physicians and are getting medication treatment for their diabetes, maybe we should be considering using the newer agents that are much more targeting cardiovascular disease risk in populations, and maybe we shouldn't be starting people on older agents that have also been shown to be helpful for insulin resistance. So the second most common was older age at onset. This was the least aggressive subtype with very few adverse outcomes, and people in this subtype may need less medications for diabetes control, or they may need less tight control. And lastly, that severe obesity subtype was the insulin resistant subtype, but they had no higher risk of developing chronic kidney disease or atherosclerosis. And so that group may be better targeted with weight loss, metformin, thiazolidinediones, other medications to really help with weight loss and insulin resistance, perhaps the newer agents like semaglutide as well. So I want to move on to show you some of our body composition data. So Dr. Anjali Gujral, who's here in the audience, led this analysis. And what she did was categorize people's body mass index based on the criteria that are used and recommended by the WHO, using normal with a BMI of less than 23 for Asians or less than 25 for all other groups. For Asians, overweight was 23 to 27.4, and BMI of greater than or equal to 27.5 was obese. And what you can see in the orange here for Masala is that South Asians had about 25% in the normal weight group, about 45% overweight, and 30% obese. Now, what does this mean in terms of, clinical risk? We know that the American Diabetes Association and the U.S. Services Preventative Task Force has recommended that people who are overweight based on 23 for Asians or 25 and over for other groups be screened for diabetes. So that's these people here get screened for diabetes. These people get a pass that you're not overweight. you don't need to be screened. And that is something that is worth looking at. So when Anjali did this analysis, she categorized people with normal metabolic risk factors versus abnormal risk factors. And this is based on the NCEP metabolic syndrome criteria for abnormal metabolic risk. And what she found was among the normal weight group that South Asians had almost 45% who had abnormal metabolic risk factors, higher than the other groups, but even the white Americans had about 20% abnormal metabolic risk factors. So everybody, 20 to 45%, South Asians just had it worse than the other groups. And so what BMI seems to be, relevant, and in this analysis, a South Asian BMI of 19.6 has roughly the same prevalence of metabolic risk factors as a white American with a BMI of 25. So what does this mean clinically? That a normal BMI is not equal to a lower risk of metabolic risk factors. And I think it's time for us to reconsider our American Diabetes Association and our US Preventative Services Task Force guidelines and leave BMI out of the recommendations for screening. Let's just screen everybody. Of course, there's the money part of it, and population health-wise, can we afford to screen everybody? Well, if we use a cheap fasting glucose test, maybe we can. Maybe not using the more expensive hemoglobin A1C, but this is something that I think really deserves some attention. So in Masala, we invested in looking at hidden fat stores. By using CT scans, we were able to quantify fat in the liver, fat around the visceral adipose tissue, fat in the muscle, and fat around the heart. And what we found for South Asians compared to the other MESA groups is that South Asians store fat in all of the wrong places. And in the top left is hepatic attenuation, which is an inverse variable. So the lower the hepatic attenuation on CT scan, the more fat there is in the liver. And you can see South Asians had significantly more fat in the liver than all four MESA groups. Visceral fat was higher in South Asians compared to Chinese, African American, and Latinos, but about the same compared to whites. And intermuscular fat in the muscle, was highest in the South Asians, and the amount of lean muscle mass was the lowest in the South Asians compared to the other groups. So this is interesting. This is that, the thin fat phenotype, and that there's more ectopic fat in the wrong places. But what does this mean in terms of diabetes risk? So here's another paper that was led by Dr. Anjali Gujral, in which she looked at progression of glycemia in 5 years, from exam 1 to exam 2. And these are people who all had the oral glucose tolerance test, and she categorized them based on normal glycemia or the 3 different pre-diabetes states or diabetes. And you can see the most rapid progression was from isolated impaired fasting glucose to later states of pre-diabetes, or from pre-diabetes to diabetes. And the overall diabetes incidence was almost 20 per 1,000 person years. And when she looked at predictors of glycemic progression, she found that both visceral fat, having more visceral fat, was associated with progressing from normal glucose tolerance to prediabetes or diabetes, but also having more fat in the liver. Remember, this is an inverse variable. So having more fat in the liver was associated with progression from prediabetes to diabetes. So both of these were important and independent of each other. So both of the ectopic fat stores seem to drive glycemic progression in South Asians. And this has led us to have kind of a overall hypothesis for what is happening. And I want to credit my good friend and colleague, Dr. Venkat Narayan, who isn't here with us in person today, but I think he's watching on Zoom. But Venkat and I have had many long conversations about this, and he was the 2015 Kelly West Award recipient. And so what we hypothesize is that there are factors that are evolutionarily determined, like poor beta cell function, as well as the low lean muscle mass. We have some nice anthropologic data that point to this, and they, in turn, can lead to impaired insulin secretion or impaired insulin action. And then there's responses to lifestyle with ectopic fat deposition in all those wrong places, in the liver, in the muscle, visceral fat, and they all together lead to increased type 2 diabetes susceptibility. So what can we do about it? So the next few minutes, I'd like to just show you our data on the multi-level modifiable risk factors. So we've used a socio-ecological model to frame how we collect data in Masala. So we've tried to measure things on the structural level, behavioral level, physiologic level, and genetic level. But the variables that I'm going to share with you today are the ones in red, but societal level variables we've been working on are different measures of social determinants of health, environment, both neighborhood environment, as well as exposures, chemical exposures in the environment, healthcare access. Interpersonal level variables are acculturation. And this is important. Remember, this is 98% immigrants that were in this study. Then we've looked at social networks and social support. And then the individual level factors are diet and exercise. So I'd like to start by sharing some of our findings, our key findings from the individual level, because those are often the easiest targets that we use as clinicians to impact change. So Dr. Meghna Gadgil is here in the audience somewhere, and she led this analysis of our diet data. So we used a 164-item food frequency questionnaire to measure diet in South Asians. And this FFQ was created and validated in Canadians who are South Asian in origin. And she combined these items into 29 groups and weighted them by serving size. And she found that there were three predominant dietary patterns that our participants were consuming. The first is the animal protein diet, which has lots of different sources of animal protein, as well as a lot of other continental foods. The second most common diet was the fried snacks, sweets, and high-fat dairy diet, which is a very traditional South Asian diet. Those of you who are familiar with this probably know a lot of those photos that I'm showing you are sweets and snacks. And the third is the fruits, vegetables, nuts, and legumes diet. And that was, low-fat dairy, vegetable oil, nuts, and other legumes. And what she found was that people consuming the animal protein diet had higher levels of total and LDL cholesterol, higher waist and weight, and higher liver fat. The ones in that middle dietary pattern, the South Asian traditional diet, had lower HDL cholesterol, higher levels of insulin resistance. And the last diet was associated with lower odds of hypertension and metabolic syndrome. And I want to also say that that middle pattern is unique to South Asians. And if you look at that middle pattern and the last pattern, most of the major components of those two diets are vegetarian items. And that is an important clinical message, because if you are talking to a patient who is South Asian and they say, I'm vegetarian, that doesn't get them a pass. You need to dig a little deeper and think, well, exactly what are you eating? Tell me how you cook your food. Tell me what sources of, what are your plant-based foods? And she's gone on to do metabolomics analysis. She's showing a very nice poster here today, looking at the different metabolites and how they track with each of these diets. And these metabolites are also associated in the poster she's showing you with incident diabetes. So Dr. Bhupataraju is a colleague at the Harvard School of Public Health, and she did a different analysis using our food frequency questionnaire data, categorizing the different plant-based foods people were eating. She gave a healthy plant-based diet index score based on who was eating whole grains, fresh fruits, vegetables, and who was eating the less healthy types of plant-based foods, refined grains, fruit juices, potatoes, deep-fried snacks. And what she found was those eating a higher index of the healthy plant-based food had lower odds of fatty liver, lower odds of obesity, overweight, and lower incidence of developing type 2 diabetes. And the people consuming more of the less healthy foods had somewhat higher incidence of developing diabetes, wasn't significant. So what have we learned about physical activity using our Masala data? Unfortunately, South Asians, I remember I showed you they had the highest education and the highest income levels. They have the lowest exercise levels compared to all four MESA groups, a very modifiable risk factor, right? We found that when we looked at those with diabetes compared to those without diabetes or prediabetes, the ones who had diabetes had the lowest exercise levels. We also found that sitting, more sedentary behavior, was associated with development of incident type 2 diabetes after adjusting for all other risk factors for diabetes. So this is important because this is a modifiable risk factor, and we just haven't been able to find the key levers to drive that intervention. So Dr. Nami Kandula led a whole social networks ancillary study, and she worked with 2 medical students to look at the influence of social interactions. And what she found in our participants were that men seemed to exercise more when they exercise with a non-spousal exercise partner. But women exercise more when they exercise with their spouses. So that's interesting. Men need to exercise twice as much. But then we did a qualitative study, kind of a deep, in-depth interviews with several of our participants to really understand the nuances of like, what are the levers that get people to change lifestyle behaviors? And it turns out it's adult children of these immigrants that are the movers of any kind of behavioral change. It's not their doctor, it's not their spouse, it's not their friend, it's not the TV, it's not news, it's not public health, it's their adult child. If they are the ones exercising, their parents are gonna change their behavior and start exercising. If the adult children say, you need to eat more fruits and vegetables, mom, stop eating those deep fried foods, that's what makes the change for the person. So this is important, and this is something that we really need to integrate into our lifestyle behavior change. Lastly, I want to show you some of our interesting data on acculturation. I like to use a quilt to represent acculturation as a symbol because all immigrant groups in the United States bring their rich heritage and culture and beliefs with them. And in the US, we integrate with different patchworks of these cultures and make a very strong, beautiful fabric. So in Masala, we measured acculturation with 9 different items, and Dr. Belinda Needham used our data to, with latent class analysis, to look at acculturation strategies. And what she found was in the orange semicircle are people who have not adopted many American beliefs or behaviors. They're in the separation class, retaining most of their South Asian traditional beliefs and behaviors, and that accounted for 20%. And then there's a bicultural integration class that has both some adopted some American beliefs and behaviors, but retained some South Asian, and that was half. And then the 30% assimilation group are the ones who've adopted more American behaviors and beliefs. And when you just look at who's in these classes, there are slightly more women in the separation class. There's fewer years in the US for people who are in the separation class, an average of 22 years, lower socioeconomic status, less exercise, but also less tobacco use and less alcohol use, and a lot more of that traditional South Asian diet that I showed you earlier. And in the assimilation group was people who had higher socioeconomic status, more exercise, more tobacco and more alcohol, but also eating that animal protein diet, that more westernized diet. And what we found when we look at how these different acculturation strategies track with metabolic risk factors is people in that separation class that's most South Asian in their behaviors and beliefs actually had the most adverse metabolic profile with highest BMI, waist, more diabetes and prediabetes, higher levels of hypertension and fatty liver. And actually it was that assimilation class, the very Americanized group, that had the best profile. This stands in contrast with other immigrant groups, from Latinx immigrants to Japanese immigrants, that the longer you stay in the US, the more assimilated you get, the worse your health gets. So there's something different happening here. And so what happens in terms of change in risk factors? So again, looking at these 3 acculturation groups over 5 years, it's a little bit more of a mixed picture. That separation class does have more change in fasting glucose. They're worsening their fasting glucose levels, and they have more change in coronary atherosclerosis. But that assimilation group is putting on more weight. They're gaining more weight and also more waist circumference. That integration group, that's the sweet spot. That's the one that actually has kind of moderate of everything. And when we looked at incident diabetes in preliminary analyses, that group had the lower incidence of diabetes after adjusting for other lifestyle behaviors. So I've been talking about how Asian Americans are not one monolithic group. Well, South Asians also are not one monolithic group. And that's why we've been spending time and energy in recruiting a new wave of participants who are Bangladeshi and Pakistani. We've added a new site at New York University, and Dr. Nadia Islam is a new principal investigator for Masala. And here's just some very preliminary findings from the first 600 people we've enrolled from these sites. And you can see the Indians are here shown on the left with a 24% diabetes prevalence, Pakistanis at 39%, and Bangladeshis at 47%. This is really alarming, and we know there will be differences in immigration stories, in acculturation, in social determinants, in diet, in cultural beliefs, and we are looking forward to actually understanding what is leading to these differences so that we can actually impact change. Just last week, Dr. Anjana and Dr. Mohan published these data, newest data coming out of most regions in India, and in red shows you all of the regions that have a prevalence of diabetes over 10%. There are 101 million people living in India who have type 2, mostly type 2 diabetes, and it's higher in urban areas, shown on the top here, all red, and lower in rural areas, and the more economically advanced states in the very north and the very south have higher prevalence of diabetes. These numbers are staggering, and it just goes to show you how urgent this is to really get on top of prevention. So in conclusion, our journey in Masala has had many conclusions, but we have seen that there is a lot more diabetes, but it varies by subgroup, and we look forward to having new data to really examine that. There is a lot more beta cell dysfunction than was previously recognized, and more ectopic fat and lower lean muscle mass as well. There's this rapid transition from prediabetes to diabetes. That speaks that we need to really intervene before prediabetes. We need to screen everybody to really figure out what's going on to get people adopting healthier lifestyle change or other changes to reduce risk. But the good news is there are many modifiable risk factors, and we need to think about how to leverage social networks, maybe adult children in the United States, to help make lifestyle changes for participants and patients. And risk factors vary dramatically among Asian American groups, and this is why longitudinal epidemiologic data is important, because we learn many new insights. So what's next for Masala? We're working on exam 3, which is phenotyping heart failure, really looking at HFpEF. We are hoping to get a new grant to measure cognitive aging in our Masala participants who are aging. One of our mentees, Dr. Nilay Shah, is doing a pilot study of the second generation of Masala, the adult children of the participants in Chicago. We've just completed whole genome sequencing and looking forward to doing a lot with those data, and we have measured chemical organic pollutant exposures, and we're going to be looking at that. And we are working with other contemporary South Asian cohorts, really trying to understand, regional differences, environmental differences, and what we can learn by combining data with UK Biobank, the CARS study in India, and the Singapore multi-ethnic cohort. I had the privilege of co-chairing this NIH workshop in 2021, and we had 30 or more investigators there to really look at the knowledge gaps in health research in Asian American, Native Hawaiian, and Pacific Islander populations. And I am so gratified to see that NIH is finally putting money towards disaggregating Asian American data and to have new opportunities for cohort studies among specific Asian American, Native Hawaiian, and Pacific Islander groups. And this is important, and I think Masala stands as an example of how this can be done and how you can leverage contemporary data from around the world to put phenotypes in context. With that, I'd like to thank everybody on our Masala team who has really made this study possible. On the top are our staff at the coordinating center at UCSF. On the right is the clinical staff. On the left bottom is Northwestern University staff and investigators, and on the right is NYU. We couldn't have done any of this without all of their support and help, and of course the participants of Masala, where all of this data comes from. I want to thank my mentors on the top row. All of them have given me so much time and so much understanding, input, and honesty in the direction of the work I do. The second row shows my dearest friends and colleagues for many, many years, and I am really grateful for them, for their support through all of the ups and downs. And then the bottom row is a list of a few of our mentees. I've tried to highlight their work and everything they've done with our study, and I look forward to them leading Masala in the future. And last but not least, I want to thank my family who's here with me today, my mom and my dad and my brother. This is our picture when we were new immigrants to the United States in 1976. And I thank them for their love and support. And then on the right, my husband, Raj, who's here with me, and our two daughters, Milan and Sonali, who couldn't make it here today. I thank them for their love and support with all of the ups and downs in life.